Assalamualaikum, good morning and salam Malaysia Madani. Welcome to IMR-SEAMEO Webinar Series 2025. I'm Dr. Siti Fatimah, Head of the Autoimmune Unit from Allergy and Immunology Research Center, AIRC, Institute for Medical Research, IMR. It is such a pleasure to be your moderator today. Whether you are a healthcare worker, doctor, nurse, medical assistant, researcher, student, or just someone curious about today's topic, thank you for being here with us. We are so glad you could join us. I'm not alone today. I have two lovely speakers from the Autoimmune Unit sitting beside me, and together we will explore the fascinating world of multiple sclerosis, or MS. But before we jump into our topic, I'd love to introduce you to the place where we work and the team behind the AIRC and Autoimmune Unit. So, please relax and enjoy this short video.
Allergy and Immunology Research Center, AIRC. Founded in 1928 and progressively developing over the decades, the AIRC has established itself as Malaysia's leading center for immunological research and specialized diagnostic services. It provides healthcare institutions across the nation with advanced expertise in various immunological disciplines. The history of the Allergy and Immunology Research Center dates back to 1928, when the IMR established a section dedicated to producing vaccine lymph for smallpox immunization. In 1930, this section was designated the Lymph Station. The Division of Serology was subsequently formed in 1946. In 1972, its name was changed to the Division of Serology and Immunology. Following the reorganization of the IMR in 2001, the division was renamed the Allergy and Immunology Research Center, AIRC. The center comprises 5 units: Allergy Unit, Autoimmune Unit, Primary Immunodeficiency Unit, Transplantation Immunology Unit, and Immunogenetic Unit, each undertaking diverse research activities and offering specialized diagnostic services relevant to immunology. In addition to diagnostic and research endeavors, AIRC manages the Malaysian Stem Cell Registry, MSCR, a digital database of volunteers who are ready to donate stem cells to patients in need of a matched unrelated donor for transplants. Established in December 2000, MSCR is a collaboration between the Malaysian Ministry of Health, Institute for Medical Research, and the National Cancer Council. Autoimmune Unit. It was established on August 16, 2010, and serves as Malaysia's referral center for autoimmune diagnostic services. The unit employs various techniques to detect autoantibodies, including immunofluorescence, enzyme-linked immunosorbent assay, ELISA, enzyme-linked immunospot, ELI-spot, immunoblot, and flow cytometry. In parallel, the unit is actively involved in both fundamental and applied research in immunology and autoimmune diseases, with a focus on discovering new biomarkers and genetic links related to autoimmune conditions in the Malaysian population, as well as contributing to mRNA vaccine development. At present, the unit offers 11 diagnostic tests for autoimmune disorders to both public and private laboratories. Anti-Aquaporin 4 antibodies, anti-N-methyl D-aspartate receptor antibodies, anti-paraneoplastic neurological syndrome antibodies, anti-ganglioside antibodies, anti-glomerular basement membrane antibodies, coeliac disease antibodies, anti-phospholipase, A2 receptor antibodies, anti-acetylcholine receptor antibodies, specific liver antibodies, skin antibodies, cytokines panel. The Autoimmune Unit actively collaborates with local universities and hospitals to advance scientific knowledge and contribute to the broader scientific community. The unit also offers laboratory training for students in subspecialty programs, as well as master's, bachelor's, and diploma programs, including laboratory personnel from both government and private institutions. Additionally, the unit offers expert consultation in autoimmune diseases and immunological conditions, including data analysis and result interpretation, providing high-quality support for clients. Furthermore, the unit coordinates the National Quality Assurance Program for Anti-Nuclear Antibody, QAP-ANA, delivering continuous assessments and educational programs for laboratories. The autoimmune team comprises a pathologist, a medical officer, a science officer, 3 research officers, 7 medical laboratory technologists, a healthcare assistant, and 3 research assistants. Please feel free to connect with us if you'd like to learn more about our services or explore potential partnerships.
I hope the video provided you with an insight into our identity and the vital role we serve in autoimmune diagnostics and research in Malaysia. Now, let's talk about today's topic, dissecting multiple sclerosis biomarkers, the unique roles of neurofilaments and Aquaporin 4. It sounds a bit technical, right? But don't worry. But first, let me ask you, have you ever heard about autoimmune diseases? Do you know what multiple sclerosis is? If your answer is no, or not really, that's totally okay. This session is designed to help everyone understand the basics regardless of your background. To kick things off, let's start with another short video that will explain what autoimmune diseases in a simple and a clear way.
Autoimmune diseases, when the body attacks itself. Normal immune function is to protect the body from harmful pathogens, produce antibodies that target foreign antigens, and distinguish between self and non-self cells. In autoimmune conditions, recognition system malfunctions, healthy tissues mistakenly identified as threats, antibodies attack the body's own cells. What causes autoimmune diseases? Genetic factors, strong hereditary component with certain autoimmune conditions running in families. Specific gene variants increase susceptibility. Hormonal factor, women are 2 to 3 times more likely to develop autoimmune diseases than men, possibly due to hormonal differences. Environmental triggers, certain infections, exposure to chemicals, medications, and other environmental factors may trigger autoimmune responses in genetically susceptible individuals. Despite extensive research, the exact cause often remains unknown and is likely a complex interplay of multiple factors. Examples of autoimmune diseases. Rheumatoid arthritis attacks joint linings, causing painful inflammation and potential damage to joints, lungs and eyes. Type 1 diabetes. Immune system attacks insulin-producing cells in the pancreas, affecting blood glucose regulation. Multiple sclerosis damages the protective covering of nerve cells in the brain and spinal cord, disrupting communication signals. Common symptoms in autoimmune diseases. Persistent fatigue, overwhelming exhaustion that doesn't improve with rest. Joint and muscle pain, ranging from mild discomfort to severe, debilitating pain. Skin problems, rashes, sensitivity to sunlight, or changes in skin texture and appearance. Low-grade fever, persistent slight elevation in body temperature during disease activity. Swollen glands, digestive issues, abdominal pain, bloating, diarrhea or changes in bowel habits. Brain fog, difficulty concentrating, memory problems, and cognitive challenges. Relapsing-remitting pattern, symptoms often fluctuate between periods of flare and remission. However, the symptom profile differs across various autoimmune diseases and among individuals with the same condition. Diagnosing autoimmune diseases. Gathering a thorough patient history, including symptoms, timeline, family history, and environmental exposures. Conducting a physical examination to identify signs of inflammation, rashes, joint swelling, or organ dysfunction. Performing blood tests for autoantibodies, inflammatory markers, organ function, and complete blood counts. Referring to specialists such as rheumatologists, endocrinologists, gastroenterologists, or other relevant experts based on the symptoms. Nevertheless, diagnosis can frequently be challenging and may require several years due to overlapping symptoms and the intermittent nature of numerous autoimmune conditions. Treatment and management. Goals: reduce inflammation, manage symptoms, prevent organ damage, induce and maintain remission, improve quality of life, minimize medication side effects. Medication: first line, corticosteroids, anti-inflammatories, immunosuppressant, biologics, targeted therapies, specific supplements, insulin, hormones, vitamins. Lifestyle modifications: anti-inflammatory diets may reduce symptom severity. Appropriate exercise maintains function and reduces pain. Stress management techniques help prevent flares. Sleep hygiene improves energy and immune regulation. Support systems. Patient groups and mental health support can provide valuable emotional and practical assistance. Common misconceptions. Autoimmune diseases are contagious. They're not. Symptoms are always visible, most are invisible. It's just in your head. Symptoms are measurable. Nothing helps. Many treatments are effective. In conclusion, with proper knowledge, support, and healthcare, people with autoimmune diseases can sustain a good quality of life and manage their conditions effectively.
I hope the video gave you an idea about autoimmune diseases. They occur when our immune system, which protect us, become confused and attack our body. It is a challenging condition, but understanding it's the first step to managing it. Today, we're focusing on multiple sclerosis, one of the autoimmune diseases, a condition that impacts the brain and spinal cord, and how biomarkers can help clinicians manage it more effectively. Before we meet our speakers, just a few quick housekeeping announcements. We won't be answering questions during the talks, but you can submit your question through the link in the YouTube chat. We will have a Q&A session after both presentations. If you'd like to get an e-certificate, please fill in the attendance form. The link is also in the YouTube chat. Don't forget to subscribe to the NIH YouTube channel and turn on notifications so you don't miss our future webinars. Ladies and gentlemen, let's start with our first speaker, a passionate and experienced medical officer from our own unit. Dr. Ainur Yusniza has more than 15 years of experience in clinical immunology and research. She holds a Doctor of Medicine from UPM and a Master in Biomedical Science from UKM. Her main work focuses on diagnosing autoimmune diseases, especially those related to the nervous system and liver. She's been involved in many national research projects, and her work has been published both locally and internationally. Today, she'll be sharing a talk titled, Reforming Multiple Sclerosis Diagnosis, a test that has proven its value. Dr. Ainur, over to you. We can't wait to hear more.
Okay, Bismillahirrahmanirrahim. Assalamualaikum and very good morning. Thank you, Dr. Siti Fatimah, for the kind introduction. It is a great honor to be here today at this IMR-SEAMEO Webinar series to share insights on the topic that is not only focused close to my professional focus, but also increasingly relevant in clinical neurology. Today, I'll be sharing on reforming multiple sclerosis diagnosis, a test that has proven its value, highlighting how recent advances are reshaping the way we identify and manage the complex neurological disease. I hope this presentation helps increase awareness and understanding the neuroimmunology diagnostic in Malaysia. I'm sure not many of us are aware of this disease. What is multiple sclerosis? Multiple sclerosis is a chronic autoimmune disease that attacks the nerve, the myelin sheath surrounding them. This causes inflammation and damage in both the brain and also the spinal cord. The exact cause is unknown. However, combination of the environmental and genetic factors likely plays a role. MS is an autoimmune disorder, meaning that the body immune system mistakenly attacks its own cell. It targets the myelin, which leads to communication problems between the brains and the rest of the body. It is a progressive disease where the symptoms are worsened over time, while the rate of progression varies from person to person, damage the nervous system, and gradually accumulate, leading to increased disability. If left untreated, it can cause severe disability. Relapsing and remitting is the most common form of MS, where the attacks of symptoms called relapses, followed by a partial or complete recovery known as remission. And lastly, it is a chronic disorder. It means it is a long-lasting and have a significant ongoing impact on person's health and daily life. Now we go to the prevalence and the risk factor associated with this condition. First, we see that it is a global reach affecting millions of people worldwide, which prevalence is 23.9 cases per 100,000 people. This highlights its significant burden on healthcare system and communities across the globe. Second, there is a gender bias, where it is more common in women than men. Third, the condition is a notable age factor. Typically, it arises between age 20 to 40. And lastly, there is a geographical influence where we observe higher prevalence in temperate climates, pointing to environment or genetic interaction that may differ by region. As you can see on the map, in the Southeast Asia, MS is the lowest compared to other regions, creates a unique epidemiological landscape compared to other parts of the world. Focusing on Malaysia per se, the data tells an interesting story. Back in 2016, the prevalence of MS was recorded as 2 over 100,000 people. However, in 2020, the number increased to 3 per 100,000 people, showing a rising trend in MS diagnosis or awareness. Despite the overall low prevalence, there is a striking pattern when we look at the gender differences. Female to male ratio is 5.1 to 1, indicating a significantly higher incidence in women. This is consistent with the global pattern where MS trend to affect women more frequently. In 2020, the incidence rate was reported as 0.3 per 100,000 people. Although MS is relatively rare in Southeast Asia, especially in Malaysia, recent trends point to a gradual increase in both prevalence and awareness with a gender disparity. Now we go to the pathophysiology of MS. On the left side, we see a healthy nerve. Notice how the axon is protected by a smooth, continuous layer called myelin sheath. Myelin acts like insulation, allowing electrical signal to travel quickly and efficiently along the nerve. Now on the right side, we see what happened in MS. As a result, the myelin becomes inflamed, breaks down, exposing the underlying fiber. This disruption slows down or even blocks the nerve signal. In the lower image, you can see clearly the difference between these two. A normal nerve has an intact myelin layer, while the nerve affected by MS show exposed fiber and severely damaged. This damage leads to a wide range of neurological symptoms. MS patients normally presented with a weakness, numbness, vision problem, and coordination difficulty. The causes of MS are multifactorial, involving autoimmunity, environmental, infectious, and genetic components. Now we go to the autoimmunity. MS is driven by autoimmune mechanism, where the immune system mistakenly attacks the central nervous system. The CD4 and CD8 T cell target the myelin sheath. Antibody also plays a supporting role in the pathogenic processes. The second one is the infection. Certain infectious agents are believed to trigger or worsen MS. These agents activate myelin-reactive pathogenic T cell, which can cause or worsen the disease by attacking the body's own nervous tissue. Environmental factors such as low vitamin D, reduced UV radiation, cigarette smoking, obesity, and exposure to Epstein-Barr virus, this factor may not only increase the risk of developing of MS, but also influence the disease progresses. And lastly, genetic predisposition. Genetics play a vital role in MS, where the MHC and non-MHC genes affect susceptibility. These genes influence the immune system, including how it responds to trigger and maintain tolerance, which are crucial in MS development. I'm going to describe briefly about the clinical symptom of MS. On the right side, we can see a summarized infographic showing the key symptoms of MS. Patients were presented with fatigue, muscle weakness, numbness, tingling, vision problem, cognitive dysfunction, walking difficulty, pain, bladder dysfunction, and muscle spasm. These symptoms may vary from person to person and can fluctuate over time, making the MS is highly unpredictable and disabling condition. There are four major clinical presentations of MS. First, relapsing remitting MS, which is the most common type. Secondary progressive MS. The third one is a primary progressive MS. And the last one is a progressive relapsing MS. And how we diagnose or how we identify this MS patient? First, by neurological tests. This helps identify any sign of nerve damage such as changes in the vision, balance, coordination, or reflexes. Magnetic resonance imaging or MRI is a key tool in MS diagnosis as it helps detect the brain lesions. Evoked potential tests, this measure the brain response to stimuli such as visual or electrical. And lastly, lumbar puncture. And before that, lumbar puncture, a spinal tap, is done to analyze the cerebrospinal fluid. In MS, the oligoclonal band detected, which is a marker of inflammation in the central nervous system. And lastly, blood tests are used not to diagnose MS directly, but to rule out other diseases that may can cause neurological symptoms like infections or autoimmune disorder. By combining results from these tests, so we can make a diagnosis of multiple sclerosis based on the 2007 McDonald criteria. For the current treatment available, which focus on the quality of life, showing a progression of the condition. First, treatment includes disease-modifying therapies, physical therapies to improve mobility, occupational therapy to aid daily tasks, and lastly, supportive care to manage symptoms and maintain the function. Now we go to the second part of my presentation. Neuromyelitis optica spectrum disorder, or also known as an NMOSD. NMOSD is a rare but serious condition. It affects the optic nerve and the spinal cord, where the immune system mistakenly attacks healthy cells in this area. This attack leads to inflammation and damage, resulting in severe symptoms such as vision loss and even paralysis. Early diagnosis and treatment are critical to managing these symptoms and also reducing the long-term disability. It is important to differentiate between the NMOSD and MS. How to differentiate between these two? Although they may appear similar, distinguishing them is critical for proper diagnosis and treatment. First, affected area. NMOSD targets optic nerve and spinal cord, whereas for MS affect brain and spinal cord. For the symptom, NMOSD often include optic neuritis and transverse myelitis, extensive transverse myelitis. For MS, it has a very varied neurological symptoms. For detection, a diagnostic marker for NMOSD is the presence of Aquaporin 4 antibody testing, something which is not found in MS. For the prognosis, when it comes to prognosis, NMOSD can be more aggressive and disabling than MS, particularly with the early and accurate treatment. And for the treatment, MS is commonly treated with the DMT or disease-modifying therapy. For the NMOSD, it requires immunosuppression. Unfortunately, in a real-world setting, patients with the NMOSD are often misdiagnosed as having MS. This misdiagnosis can delay the appropriate treatment and worsen the outcome. Next, I'll be talking about Aquaporin 4. Aquaporin 4 or AQ4. These are specialized water channels which are essential for regulating water movement within the brain. They help maintain neural hemostasis, which means keeping the brain environment stable and healthy. Aquaporin 4 channel could also influence several processes like synaptic activity, brain metabolism, and the fluid balance. The image on the right side shows water molecule passing through Aquaporin 4 channel, which is embedded in the cell membrane. Now we go to the role of the Aquaporin 4 in the brain health. The physiological of Aquaporin 4 in the brain include synaptic plasticity, brain volume control, neuronal excitability, and the potassium clearance. Aquaporin 4 is a water channel protein and it is recognized as a key target in managing neurological disorders. This protein play a role in regulating brain water balance, which made it essential during conditions like brain edema. It is involved in the brain edema, blood-brain barrier, neurological cell death or apoptosis. Aquaporin 4 also play an important role in the waste clearance through the glymphatic system. And its pathological implications include brain tumor invasion, neuromyelitis optica, and the brain edema. Now we go to the role of the Aquaporin 4 in association with the neurological disorders. It has a role in edema, where Aquaporin 4 associated with brain edema, where it facilitates water transport across the cell membrane. Next, Aquaporin 4 antibody are crucial for differential diagnosis. Their presence help to rule out MS and point towards other disorders such as NMOSD. For detection of NMOSD, Aquaporin 4 are seen and detected. Interestingly, Aquaporin 4 also been studied in migraine association. It has been implicated in triggering and exacerbating migraine attack, although the exact mechanism are still being under research. Lastly, clinical studies are ongoing to understand the Aquaporin 4 antibody, Aquaporin 4 role, and to develop the targeted therapies. Therefore, Aquaporin 4 plays a vital role not just in the fluid regulation, but also in diagnosing and understanding several neurological disorders. Now we go to the symptom and diagnosis of NMOSD. Let's go through the main symptom of NMOSD. First, we have the optic neuritis. This is the inflammation of the optic nerve that can cause pain with the eye movement and reduce vision. This inflammation leads to significant vision loss if left untreated. Next, patients usually present with the blurred vision or even complete blindness, which result from the damage of the optic nerve. Then we have a myelitis. This leads to symptoms such as weakness or paralysis in the limb, sensory disturbances, bladder or bowel dysfunction, and the spinal cord inflammation can be severe enough to cause long-term disability if not managed properly. The key diagnostic tool for NMOSD is anti-aquaporin antibody test. This blood test looks for antibodies that is specifically test Aquaporin 4. A positive test result strongly support the diagnosis of NMOSD. The Aquaporin 4 antibody is important in confirming the diagnosis. Now we go to Aquaporin 4 antibody. What is Aquaporin 4 antibody actually? It's a protein found in astrocyte. It mainly regulates water movement through a special channel. However, when the immune system produces antibody against Aquaporin 4, it can disrupt its water regulation and leads to serious central nervous system disorder. One of the main conditions associated with the Aquaporin 4 antibody is a neuromyelitis optica. This condition involves inflammation of the spinal cord and the optic nerve. Aquaporin 4 antibody are considered a key marker for its diagnosis. In fact, this antibody can be detected more than 75% of patients with the NMOSD and about 50% of patients with the extensive transverse myelitis. This illustration shows how antibody in green target the Aquaporin 4 channel, in blue damaging the surrounding cell and contributing to the disease process. Aquaporin 4 antibody in autoimmune disorders. First, Aquaporin 4 antibody play a central role in pathogenesis of neuromyelitis optica. Second, this antibody serves as diagnostic marker. And lastly, as a therapeutic target. Now I'll be focusing on the clinical significance of Aquaporin 4 antibody in in NMOSD and focusing benefit they provide. First, as a biomarker, Aquaporin 4 serves as a specific marker for NMOSD. It helps distinguish NMOSD from the classical multiple sclerosis. By identifying the Aquaporin 4 antibody early, we can facilitate timely and targeted treatment, potentially reduce the severity of future relapse. It is important in patients with the optic neuritis and the transverse myelitis. These are the two hallmarks of the symptom of the NMOSD. The presence of Aquaporin 4 antibody in this patient support the diagnosis of NMOSD. Lastly, Aquaporin 4 antibody level may be useful in tracking disease progression and helping clinicians adjust treatment over time. Later, I would like to share the experience and the insight of Aquaporin 4 antibody testing in the autoimmune laboratory. This slide summarizes the essential aspects of the Aquaporin 4 antibody test, including sample type, testing method, test availability, and also result interpretation. First, the type of sample that can be used for this test includes serum, which is collected in the plain tube, and the cerebrospinal fluid, which is collected in the visual bottle. These samples are necessary to detect the presence of anti-Aquaporin 4 in the patient. The testing method used is indirect immunofluorescence test. This technique involves applying the patient sample to a substrate, followed by the fluorescent labeled antibody, and the fluorescence is then observed under the microscope, which help determine the presence of or absence of the specific antibodies. And this test is available in all hospitals across Malaysia. And lastly, the results are interpreted visually. A positive result shows a bright green fluorescent pattern as seen on the left, and negative result appear dull or non-fluorescent as shown on the right. This pattern helps differentiate between positive and negative antibody presence. Now I'm going to describe briefly about the process of how test reports are managed and assessed during the sample using the Sample Management Information System or SMIS. Let's begin with the first step. The test request can be made directly to SMIS. The request form you can obtain via IMR website, allowing requester to easily initiate the request. Once the samples are received and processed, the results are entered into the Integrated Laboratory Information System or E-list. This system ensures accurate and organized reporting of test data. And lastly, the test reports are released and made accessible through SMIS. All authorized requesters can log in and retrieve their results seamlessly. In this slide, I would like to show our annual workload related to anti-Aquaporin 4 antibody testing from year 2020 to 2024. This bar chart showing the number of samples received each year. We receive approximately about 600 to 700 samples each year. And this slide shows the percentage of positivity of anti-Aquaporin 4 antibody from 2020 to 2024. We found out that around less than 10% of the total sample received were positive for anti-Aquaporin 4 antibody. Now we go to the clinical and diagnostic differences between the NMOSD and also MS. Starting with the MS symptom, patients typically experience sensory loss, muscle weakness, as well as a balance and coordination problem. These symptoms often appear in episodes and tend to progress gradually over time. In contrast, for NMOSD, symptoms are usually aggressive. Patients tend to have severe attacks from the very beginning. This attack comes with a high risk of disability even from the first episode. Unlike MS, NMOSD usually does not progress between the attack, and the damage occurs suddenly and is not a continuous. When it comes to the optic neuritis, it is milder in MS and severe in NMOSD. Lastly, looking at the antibody marker, a major diagnostic distinction is the presence of the Aquaporin 4 antibody. This antibody found more than 75% of the patient with the NMOSD. In MS, currently there is no specific antibody marker were identified. So in summary, MS and NMOSD may seem similar, but the symptoms, progression pattern, and diagnostic marker are distinct. And recognizing these differences is crucial for accurate diagnosis and treatment. Here we come to the end of my presentation. I can conclude that multiple sclerosis is a chronic autoimmune disease affecting young adults, mostly common in female. NMOSD is a distinct disorder that requires differentiation from MS. Aquaporin 4 testing is essential for accurate diagnosis and targeted treatment. And finally, early recognition and accurate diagnosis are critical. They significantly improve patient outcome and help prevent unnecessary complications. Before I end my presentation, I would like to take this opportunity to express my sincere gratitude to the Director General of Ministry of Health Malaysia for granting this permission to present in this IMR-SEAMEO webinar, and to all AIRC and also autoimmune staff. Their support and endorsement has been invaluable in making this presentation possible. Thank you for your time and attention. Hope you found this presentation informative and impactful. Now I would like to pass to our moderator, Dr. Siti Fatimah, for the next session. Thank you.
Thank you, Dr. Ainur, for that clear, informative, and eye-opening presentation. To our audience, if Dr. Ainur's talk sparked any question in your mind, we'd love to hear them. Just drop your question in the YouTube chat via the link provided, and we will get to them during the Q&A session after our second speaker. So now, let's keep the momentum going as we welcome our next speaker. Next up, we have Dr. Shuwahida Shuib, a dedicated research officer at the Autoimmune Unit. She holds both a bachelor's and PhD in microbiology from UKM, and she has over 10 years of experience in research, including immunology, vaccine studies, and medical biotechnology. Her current project focuses on a biomarker called Serum Neurofilament Light Chain, SNFL, a simple blood test that could help doctors track the progress of MS. She also played a key role in several COVID-19 vaccine studies during the pandemic and has won multiple Best Poster Awards for her research. Today, she will be giving a talk titled Exploring Serum Neurofilament Biomarker, showing how these tiny molecules can give big insight into brain health and disease activity. Dr. Shuwahida, the stage is yours.
Okay, thank you Dr. Siti Fatimah for your kind introduction. Assalamualaikum and very good morning everyone. Thank you for joining this SEAMEO webinar session. I am Dr. Shuwahida Shuib, a researcher from Autoimmune Unit, Allergy and Immunology Research Center, AIRC, Institute for Medical Research, IMR. It is a privilege to be invited to present on the topic that closely related to my research area, neurofilament light chain. It's a frontier in monitoring neurological diseases. I hope today's session will be informative and spark further interest in the clinical application of this promising biomarker. We are going to explore into this exciting topic now, but first thing first, please allow me to briefly explain what biomarker is. Biomarker is a measurable indicator of a biological state or condition. It can be a molecule, gene, enzyme, hormone, or other substances that found in blood, body fluids, or tissues that indicates normal or abnormal processes or disease. Biomarkers are commonly classified into these following types based on their function. Diagnostic biomarker identify the presence of a disease or condition, for example, troponin for myocardial infarction. Prognostic biomarker predict the likely cause or outcome of a disease, for example, serum neurofilament light chain for future MS progression. Predictive biomarker forecast the response to a specific therapy, for example, HER2 for trastuzumab response in breast cancer. Then we have pharmacodynamics or response biomarker, indicate biological response to a treatment, for example, decreased CRP after anti-inflammatory therapy. We have the monitoring biomarkers, track disease status or treatment effectiveness over time, for example, HbA1c in diabetes. And lastly, we have the susceptibility or risk biomarker that indicate the likelihood of developing a disease. For example, BRCA1 or 2 mutation for breast or ovarian cancer risk. Among the many types of biomarkers, neurofilament light chain stand out as a highly specific indicator for neuronal injury. To understand why it is so valuable, let's first look at what neurofilaments are and how they function in the nervous system. Neurofilaments are types of protein found in the cytoplasm of neurons and are particularly abundant in axon. They contribute to the structural integrity of the neuron and are crucial for maintaining axon caliber or diameter, which influences nerve conduction velocity. They also play a role in axonal transport and involved in cell signaling. Neurofilaments are composed of several proteins, most notably neurofilament light chain or NFL, neurofilament medium chain or NFM, and neurofilament heavy chain or NFH. These proteins have characteristics into rod-shaped domains that allows them to assemble together to form a neurofilament. This slide compares a healthy neuron with one undergoing damage in neurological diseases such as multiple sclerosis. In the healthy state, oligodendrocytes maintain the myelin integrity and support the axonal structure, keeping neurofilament stable. However, in disease conditions, immune cells like T cells and microglia infiltrate the CNS, leading to the oligodendrocyte loss, demyelination, and direct axonal injury. This disrupts the cytoskeleton and causes the neurofilament light chain to leak out into the cerebrospinal fluid and eventually to the blood. When the nerve cells are damaged, the level of serum neurofilament light chain in blood increases. Measuring neurofilament light chain in blood allows clinicians to quantify ongoing neuronal injury, making neurofilament light chain a powerful, minimally invasive biomarker for detecting and monitoring neurological diseases. Neurofilament light chain can be a biomarker for several neurological diseases, including multiple sclerosis, Alzheimer's, and Parkinson's diseases. Whether it is the slow degeneration of nerve cells in Alzheimer's or the immune cell attack the nerve cell in multiple sclerosis, measuring neurofilament light chain helps clinicians to understand how much damage is occurring and how best to treat this condition. We are moving towards individualized monitoring by rethinking conventional methods and adopting more accessible tools to track CNS damage in real time. The most significant role is currently played by the CNS lesion load assessed by the magnetic resonance imaging or MRI, as well as the clinical features, for example, relapse rates and disease progression. Nevertheless, While it is possible to measure and standardize the characteristic in the larger patient populations, however, it is not feasible for individual patients until now. Therefore, there is a need for easier to perform and easily accessible biomarker that's suitable for continuous monitoring for disease individually in clinical and routine diagnostic setting. Measuring neurofilament light chain in blood offers several important advantages. First, it provides minimally invasive way to detect the nerve cell damage, avoiding the need for more invasive procedure like lumbar puncture. Second, blood neurofilament light chain level can reflect real-time neuroaxonal injury, making it useful for early diagnosis, monitoring disease progression, and assessing treatment response. And third, blood-based testing is easier to standardize and scale, making it more accessible for routine clinical use. Finally, it is broadly applicable across many neurological disorders, including multiple sclerosis, Alzheimer's, and traumatic brain injury. To measure serum neurofilament light chain in blood, we can use two main methods, ELISA and single molecule array technology, or known as SEAMEO. ELISA is a well-established method that cost-effective and relatively easy to use, but its sensitivity is limited. It works best for detecting neurofilament light chain in cerebrospinal fluid. On the other hand, SEAMEO is a next-generation digital immunoassay that can detect extremely low concentration of neurofilament light chain in serum, down to the femtomolar range. This makes SEAMEO especially useful for early diagnosis and monitoring of neurodegenerative diseases. While SEAMEO is a little bit expensive than ELISA, it is highly sensitive and reproducibility make it the current gold standard for serum neurofilament light chain quantification. Okay, now let's take a closer look at multiple sclerosis, or MS. MS is an autoimmune disease where the body immune system attacks the protective covering around the nerve cell fiber called myelin. This causes inflammation and damage to the nerves, which disrupt communication between the brain and the body. As the nerve cells are damaged, the neurofilament light chain in blood rise. So, neurofilament light chain is a helpful tool for clinicians to track the MS disease activity. Living with multiple sclerosis places a significant physical, emotional, and financial burden to the patient. The unpredictable nature of the relapses, progressive disability, fatigue, and cognitive decline can severely affect daily functioning, independence, and quality of life of the patient. Many patients also face psychological challenges like anxiety and depression, along with the difficulties in employment and social participation. On top of this, long-term treatment, regular monitoring, rehabilitation impose substantial healthcare costs. Understanding this burden highlights the urgent need for a better tools to monitor disease activity and guide more timely and personalized treatment decisions. This is where neurofilament light chain play an important role. As a marker of a nerve cell damage, neurofilament light chain can be measured in blood to detect and monitor disease activity in MS. Unlike conventional tools like MRI or clinical assessment, neurofilament light chain offers a minimally invasive, cost-effective time. By integrating neurofilament light chain into routine care, clinicians can make earlier, more informed treatment decision, and ultimately improving patient outcome and reducing the long-term burden of MS. Now let's explore into how neurofilament light chain help manage MS. First, neurofilament light chain is a sensitive marker for neuroaxonal damage. It excels where the traditional method may fall short, often highlighting injury even in the absence of clinical symptoms. This sensitivity allows us to detect subclinical disease activity and silent progression, giving us an edge in managing MS. Next, neurofilament light chain supports treatment monitoring and helps predict relapses. It gives us a clearer picture of what's happening beneath the surface. Elevated neurofilament light chain levels can alert us to potential issues before they manifest clinically, allowing for timely intervention. Finally, by integrating neurofilament light chain into routine care, we can make more personalized treatment decisions. This means that each patient care tailored to their specific needs, which can lead to better outcomes and reduction in the long-term burden of MS. Ultimately, neurofilament light chain provides us a powerful tool for earlier and more informed decision-making in MS management. Our team at IMR and HKL have conducted the pioneering Malaysian study on serum neurofilament light chain in patients with multiple sclerosis. We utilized the cutting-edge technology of single-molecule array, or known as SEAMEO, to measure the serum neurofilament light chain levels in multiple sclerosis patients. This technology is highly sensitive, allowing us to pinpoint even subtle changes. The goal was to quantify the levels and explore their relationship with key clinical parameters such as patient relapse histories and their disability status. Our research contributes to valuable local data to the global effort of validating serum neurofilament light chain as a reliable biomarker for neuroaxonal damage in Malaysian population. To investigate serum neurofilament light chain level in MS patients, we began by collecting 2 ml of blood and clinical data from each patient. The blood samples were processed by centrifugation at 2,500 RPM for 10 minutes, and the serum was aliquoted into the clean Pandolph tubes and stored at -80 degrees Celsius to preserve the protein stability. We then used the single-molecule array platform, or SEAMEO, by Quanterix to quantify the serum neurofilament light chain concentration. This technology offers ultra-sensitive detection, allowing us to measure neurofilament light chain even at the very low-level concentration typically found in serum. The final step involves statistical analysis to assess the association and correlation between serum neurofilament light chain level and clinical features such as relapse history, EDSS score, and lesion count on MRI. This entire study was conducted under ethical approval from the Ministry of Health Malaysia under the register project ID NMRR 222337 56904. In our preliminary analysis, we observed that serum neurofilament light chain level were significantly higher in MS patients compared to healthy controls. This finding supports the role of serum neurofilament light chain as a marker of ongoing neuroaxonal damage. More importantly, we found a positive association between serum neurofilament light chain levels and three clinical parameters. First, the Expanded Disability Status Scale, or EDSS score. Second, the number of relapses reported by the patient. And third, the number of the CNS lesions observed on MRI. This correlation suggests that higher serum neurofilament light chain levels may reflect greater disease burden, reinforcing its potential as a non-invasive biomarker for monitoring disease activity and progression of MS. To conclude, serum neurofilament light chain may be tiny in size, but its impact is anything but small. It offers a window into the brain, reflecting real-time damage and disease activity without the need for invasive procedure. By correlating strongly with relapses, disability scores, and lesion load, serum neurofilament light chain hold great promise not just as a research tool, but as a clinical game changer. With continued validation and integration, we are looking at future where neurological disease can track more precise, managed more effectively, and hopefully predicted earlier than ever before. Before I end up this session, I would like to express my sincere gratitude to the Director General of Health, Ministry of Health Malaysia, and the Director of the Institute for Medical Research IMR for granting us permission to present this work. I also want to thank the Neurology and Radiology Department of Hospital Kuala Lumpur for their collaboration and support in patient recruitment and data sharing. And special thanks to all dedicated staff of Allergy and Immunology Research Centre, AIRC, particularly the Autoimmune Unit staff, for their continuous assistance throughout the study. And most importantly, I would like to thank the patients who generously participate in this research. Thank you all for your time and attention and interest in this topic. I hope this session has provided valuable information into the potential of serum neurofilament light chain as a tool for monitoring neurological diseases. With that, I now hand this session back to our moderator for the Q&A section. Thank you once again, and back to you, Dr. Siti Fatimah.
Thank you so much, Dr. Shuwahida, for that informative and thought-provoking presentation. It is incredibly inspiring to see such impactful research happening right here in Malaysia, and even more so when it holds real promise for improving patient care. Alright, ladies and gentlemen, now it's time for our Q&A session. We already received some questions through the chat. Please keep them coming, and I will do my best to connect you with our distinguished speaker through the posted question. However, if time does not permit us to address all questions, our speaker will do their best to answer them via email. So, let's start with the first question for Dr. Ainur. The question from Ms. Adila Bertam, Pulau Pinang. Is the antibody testing available in all government hospitals in Malaysia?
Thank you, Dr. Siti, for the question. And thank you, Ms. Adila from Bertam, Pulau Pinang. Yes, we are the only lab that perform the test, and it's the only available test in Malaysia, which is in our lab, in Autoimmune lab in IMR. Thank you.
Okay, thank you, Dr. Ainur. The second question for Dr. Shuwahida. How is measuring NFL different from other methods like MRI? From Nurul Fariza, UPM Serdang.
Okay, thank you, Puan Nurul Fariza. Measuring neurofilament light chain is a faster, easier and non-invasive method compared to the traditional MRI scan. MRI scan can detail but require the patient to undergo a procedure that can be time-consuming and sometimes uncomfortable. In contrast, measuring serum neurofilament light chain is simply involve a blood test, which can be done quickly without causing any discomfort. It provides a real-time information about the nerve cell damage, whereas MRI scan can sometimes only show the damage after it's happening. Thank you.
Thank you, Dr. Shuwahida. The third question for Dr. Ainur from Afiza, Kuala Lumpur. Do patients need to pay for this test? I think she means Aquaporin 4 in the public healthcare system.
Okay, thank you, Dr. Siti, for the question, and thank you, Ms. Afiza. For all government hospital under KKM, it is free. We don't charge. Meaning that no need to pay for the cost for the test, and we only charge for private hospital or private lab, which is we charge RM 450 ringgit. Thank you, Dr. Siti.
Okay, thank you, Dr. Ainur. So now, I'm afraid that is all the time we have for the Q&A session. Any questions that haven't been answered yet will be responded to by the speakers via email. And just like that, we've come to the end of today's session. A big thank you to our two amazing speakers, Dr. Ainur and Dr. Shuwahida, for sharing their knowledge and expertise. And of course, thank you to all of you who joined us, whether from your office, home, or even with your phone. We hope you learned something valuable and enjoyed the session. Don't forget to fill out the attendance form to get your e-certificate. And our upcoming IMR-SEAMEO webinar will be revealed soon. Don't miss out, so subscribe to the NIH Malaysia YouTube channel now and be the first to catch it. Before we conclude, let's take a moment to celebrate the spirit of Merdeka. 1st August marks the beginning of Merdeka month, with the theme for this year being Malaysia Madani, Rakyat Disantuni. Let's proudly fly the Jalur Gemilang everywhere we can, as a symbol of our love, pride, and unity as Malaysian. Until then, take care, stay curious, and we look forward to seeing you again soon. Thank you and Assalamualaikum.